The nurse in the home care setting requires expertise to care for a child who is technology dependent, and this child is very technology dependent. And like I told you, if you ever learn trach vent care, there is a lot of money to be made in it. You can make like $30 an hour for most agencies. Family-to-family support. We need to evaluate the family support systems, networking with other families of special needs children, and respite care for these families. This is worked out with the HMO, and it's also worked out prior to discharge. We want to get this family some support because you have to think that they are 24/7 with these children in the home with all this technology and all of their special needs. And once you leave the hospital, you lose that kind of support. So we want to make sure that we have them well situated in their settings. We'll discuss some of these questions that I've put out in the chapters here. We'll discuss the questions in class today. We're going to move on now to Chapter 21. It's family-centered care of the child during illness and hospitalization. Stressors of hospitalization. There's separation anxiety, the protest phase. They cry and they scream and they cling to their parents. And then there's this despair phase where the crying stops and they're evidently depressed. Detachment phase, denial, resignation, but not contentment. May seriously affect attachment to parent after separation. And this, we're talking on a long-term, basis. We're not talking about an overnight stay. Here's your separation anxiety. Protest phase, separate. Makes the parents feel very, very guilty, especially when their child is being held by someone else and they call out to them and they put their hands out. You know how guilty that makes you feel. And this is a despair phase where there's separation anxiety. Children are sad, lonely, and uninterested in food and play. Loss of control, infants' needs. Trust, consistent, loving caregivers, and daily routines. Think about Piaget and Erickson about the trust versus mistrust. Think about those stages that this child is in, and it'll be easy to see the situations that they're going to come up with and the actions that they may have. Their daily routines are definitely disrupted. How can they trust strangers? They see faces that aren't their parents. They don't know why they're sick. They don't know why they have pain. They don't know why they're there. They feel abandoned. Their parents left them. And if you can have like the same nurses, it's very nice when we can work with just maybe 2 or 3 caregivers to give this child a little bit of comfort and try to build some trusting relationships. Toddlers' needs for autonomy. Their daily routines and rituals. Mom and dad are encouraged to bring their blankie, their little teddy bear, or whatever brings them comfort, that little comfort toy or blanket, to bring that in with them. They're going to lose control of all of their other things in their environment. We allow them to play, we allow them to do things, but we also are in charge of them. We have to make sure that they get their medicines and their treatments and that they don't put themselves in harm's way in a strange environment, as well as it might be not good for them physically when they're feeling not well to be doing too many activities. Loss of control may contribute to the regression of behavior. We've talked about children that are perfectly potty trained and maybe even toddlers. They haven't wet their pants for years. Now they may go back and have those behaviors. They may suck their thumb. They may regress. They may behave negatively and temper tantrums. When they don't get their way, they can really, really act out. And they don't know us, so they're going to try to press all our buttons and see how far that they can go. They know what to do with their parents, but they don't know quite what to expect from us. Preschoolers. They're egocentric and magical thinking, typical of their age. They view illness or hospitalization as a punishment for something they did wrong. Pre-operational thought. That's the stage they're in. The school-age child. He's striving for independence and productivity, fears death, abandonment, or permanent injury. And they get bored really, really fast. Adolescents. They struggle for their independence and liberation. They're separated from their peer group. They can respond with anger and frustration and need for information about their condition. And this is really, really tricky because we got to meet with the parents, especially if it's a serious situation. It's not just a sore throat or asthma or something that they've had exacerbations with. If this is a new diagnosis, you want to be careful about how much information you share prior to having one of these meetings with the parents and the doctor and all of that, and how we are going to approach this adolescent and tell them about this condition. You don't want to lie to them, but you might not be able to share all the information with them at the time that they ask. They fear bodily injury and pain. A lot of times they come in pain. Common fears amongst children are pain. They persist into adulthood and result in avoidance of needed care, especially with chronic illnesses. Effects of hospitalization on the child. Effects may be seen before admission, during hospitalization, or after discharge. Child's concept of illness is more important than intellectual maturity in predicting anxiety. So we need to find out how they feel about this. And if it's something that they're going to have to live with the rest of their life, then we want to work on some positive aspects of this and maybe get them into talking to a counselor about, their special needs. Individual risk factors that increase vulnerability to stressors of hospital. Difficult temperament. Lack of fit between the child and parent. Age, especially age 6 months to 5 years. Male gender. Below average intelligent. Multiple and continuing stressors such as frequent hospitalizations. These risk factors are, if that child's in and out, in and out, in and out, that gets old really quick. And then they will learn how to play other games. They'll learn how to be very, very manipulative. Some of the things that can happen in the hospital that are positive, we do have some positives, are recovery from the illness, the increased coping skills, master stress and feel competent in coping, and new socialization experiences. Parental response to stressors of hospitalization. Disbelief, they can be angry or feel guilty, especially if the illness is sudden or if it's serious. Nobody wants to feel that their child is sick because of them, something that's in their history, something that's in their genetic makeup, and that can make a parent feel very, very guilty to see their child suffer with something that was caused by them. They have fear and anxiety. They don't like to see their child in pain or seriously ill. There's frustration. They want information, and sometimes we don't always have it. We have to wait for the testing process to be completed. We have to wait till we gather all of our information. And even then, sometimes we just don't know until a little bit more time has gone on, or until we send them away for a special test, or time itself may take care of it, that the seriousness of their illness starts to surface. And they can get very, very depressed. And you can understand why. Siblings can be lonely. They can fear or worry. They're scared. Is my little brother going to die? Why is he in the hospital? Why is he sick? Am I going to get sick? They can feel anger and resentment and jealousy. That child's getting all the attention. Mommy and daddy are spending all their free time down at the hospital. Who's worried about me? And they can feel guilty. They can feel guilty about their brother got sick, but they didn't. Sometimes they worry too about feeling bad because they feel bad. Oh, gee, he's getting all the attention and I'm not. And then they start to feel guilty about it, that they shouldn't have thought that way. Anger and jealousy between siblings and the ill child. And that's a very, very natural thing. Sibling rivalry when the new baby comes home. Well, there's sibling rivalry when that person, that little sick guy, is getting all the attention. Ill children feel obligated to play the sick role. Parents continue the pattern of overprotection and indulgent attention. It comes from that guilt factor. You feel really, really bad that that child is sick and that there's nothing that you may be able to do about it. So then you protect them and you feel guilty. Preparation for hospitalization. If it's a surgery that's elective or something that comes up that we have some time to work with, we can do our nursing process by assessing the situation. How prepared is this child? You can make your nursing diagnosis. You plan on all the things that we're going to do while they're under our care. And then we want to put our implementation to work, and then we will evaluate. We're only second guessing because we don't know this child, and we're going to give it the best shot that we can with our nursing process, especially if we get a little advance notice that this child is going to come in under our care. Primary nursing goal, especially for children less than 5 years old, is to minimize that separation. We allow the parents to stay there. We put in lazy boys in the room now, and the moms, dads can stay there with the children. Family-centered care. And parents are not visitors. They're allowed to stay. Familiar items from home are brought in, especially if the child's going to be there for any length of time. Normalizing the hospital environment. We maintain the child's routine if at all possible. Time structuring. Self-care. Age appropriate. Let them do for themselves as much as they can. We might have the school provides visiting teachers, so we may have one of them coming into the hospital. And we allow friends and visitors, and we can be a little bit more flexible today than we ever could. But if the child has a really serious or a contagious illness, then that's going to limit the socialization there. But for the most part, if it's something that we can work around, we will try our best to meet the needs of the socialization of that child. Family involvement. When parents cannot visit and other significant persons can provide comfort to the hospitalized child. Aunts, grandmoms, anybody that come and visit that child in between. Mom has other responsibilities or the parent may be working. And that can help out too. Parental presence during hospitalization provides emotional support for a child and increases the parent's sense of control. Nursing care of the family. Do a family assessment. Discharge assessment and planning. We encourage the parent participating in planning of care. Information. Preparation for discharge and home care. If we can find out as much as we can, this will help the parent to be able to take this child home with these special needs. And if they're going to have further care in the community or people in their home, like the visiting nurses or shift nursing, we want to prepare them as much as we can. We want to get as much information from them as we can to make it a smooth transition. They're going to have enough stress as it is, getting home and getting settled that anything we can do to make this flow smoothly will add a lot of comfort to these parents.